Okay, we've got most of everyone here now, so we'll go ahead and get started. Thank you for joining us for our second webinar, introducing the project PaReNts that we will be working on starting this summer. And we're glad everybody could make it. And a little outline of what we'll be talking about today. First, we'll do a little get to know you poll, and then we'll turn over the time to Dr. Stockler, who will be talking about core outcome sets for creatine deficiencies. And at the end, we will have a question and answer session, as well as discuss the next steps in this project. So let's get started with our first poll. Just look for the poll to pop up on your screen and click on the answer that's best for you. Our first question is, what region are you joining us from? And while I watch these answers come in, I can't vote, but I am in Salt Lake City, Utah area. Here we go. That poll did not come through properly. So let's give it another shot if we can, Faith. Let's ask everyone again, what region are you joining us from? Okay, which disorder are you here representing? There we go. You should see a little pop-up in front of your webinar, and if you'll just click on which disorder you are representing, I can share the results with you in a minute. Well, we had this ironed out last week, but we're having an issue with our polls. So we'll just go ahead and I'll let you think about what are your plans for this weekend. I know it's almost the end of the day, Friday, and I'm ready to start my weekend. I think I'm probably B. If you can vote, we'll give this one more shot and see if we can see the answers to this one. All right, there we go. Okay. We've got a tie between B and D. I'm sorry for everyone who has laundry to look forward to. But I'm glad you all joined us, and hopefully this is a good kickoff to your weekend. So at the end of Dr. Stockler's presentation, we will go through the questions that are posted in the Q&A box. So please post any questions you have during the webinar, and we will get to them at the end. And just a quick overview of who is involved in this project. Dr. Stockler is our co-primary investigator, and we have 3 researchers working with Dr. Stockler as well, Delia, Zara, and Beth. And then last week you met our patient engagement advisor, Maureen. She is part of this project to make sure that everything we do is friendly and considering the patient and their needs. And then in our team, we have Laura Trutoyu, our director of research, as our primary investigator with ACD, and I will serve as the project coordinator, and then Faith is our administrative coordinator. And then in addition, as we will talk about more, we will have a caregiver cohort of 20 families that will be selected to participate during this project, and additional experts who will be recruited to assist Dr. Stockler, and as well as outside clinicians who will be invited to attend sessions to learn more about CCDS. So now I will turn the time over to you, Dr. Stockler. Thank you.
Yeah, thank you, Heidi, for the introduction. I'm going to talk about a project that we've called Course for CDS. Next slide, please. And this is actually within the framework of the PaReNts project, which is a PCORI grant awarded to ACT and which aims to empower patients and families to contribute as research partners in joint patient and medical expert efforts and to advance the understanding of CDS. So the whole project is about these bullet points. Next. And there will be a demonstration project where we can show that we are engaging patients and researchers at the same time. And this is actually the Course for CDS, which is a project where we want to develop core outcome sets for the assessment of therapies, mainly new therapies for creatine deficiency syndromes. And at this point, we're focusing on two creatine deficiency syndromes, namely GAMP and creatine transporter deficiency. We have not looked into AGAT deficiency because I think there are almost no patients available, and we know very little about this disease. Next slide. So I would like to explain the terms used, because if you hear the word outcome, core outcome set, maybe many of you don't know exactly what it is. And I also would like to explain the aims of the Course for CDS, namely how we're gonna develop those core outcome sets for creatine deficiency syndromes. And with that, we will also show the areas of input from you and from clinical experts in this project. Next one. So the main part of this talk will be about definitions, because we need to find a shared language for a mutual understanding. So we all need to know, what do we mean when we speak about outcomes and core outcome sets? So let me talk a little bit about that. Next one. So outcome, I looked it up in all kinds of dictionaries, how this word is defined. And it is a way a thing turns out, a consequence or an end result of an action. So you would ask, what is the outcome of your efforts? Or nowadays we would ask, what is the outcome of Joe Biden's negotiations with Vladimir Putin in these kind of times, where we are talking about probably wars. Next slide. But when we look into clinical research, outcomes are defined more specifically. So in clinical research, outcome describes a change in health as a result of the disease course, for example. So an example that relates to creatine deficiency syndrome is in a boy with creatine transporter deficiency. How are his language abilities at the age of 10 years different from compared to 5 years? Has there been any change? Has there been an improvement or deterioration in this particular outcome, in the outcome of language ability? In clinical research, outcome is also used as a chain to describe changes in health as a result of a treatment. So not only of a clinical course where we're just observing over time what happens with a patient, but where we are also observing what happens with a patient when that patient is on a treatment within a clinical trial, for example. So again, coming back to the boy with creatine transporter deficiency, in this context, we would ask, how are his language abilities after 1 year of a treatment, for example, with creatine? This is the only thing we have at the moment for these patients, but hopefully in the future we will have more. Has there been any change due to the treatment? Has there been an improvement, is the same, or a deterioration? So in this context, the language abilities would be one outcome for, as a tool to assess the treatment. Next. So where do these outcomes come from? How do we know what could be a good outcome for, to measure? And then we have to go back to what we understand with symptoms. So when we describe a patient's condition, for example, if you read a publication about GAMT deficiency, about the clinical presentation of GAMT deficiencies or of creatine transporter deficiencies, we don't speak about outcomes. So nobody will say, well, language delay is an outcome, but we would use terms as symptoms, signs, manifestation, presentation. So in papers describing a disease, how patients manifest, one would speak about symptoms. So one would say a patient has language delay, that is a symptom. But if we say the language delay is improved after treatment within a trial, then we would say outcome. So language delay was an outcome of this clinical trial. So it's kind of the same. It's just used, there are just two different words used in different contexts. Next one. So what we're mostly interested in at this point, of course, are clinical trials, because we are expecting new treatments for creatine deficiency syndromes in the future. And as we all know, but just as a kind of repetition, clinical trial assess the effect of a treatment or on one or more symptoms of a disease. And when we show how the treatment has changed the symptoms, we speak about outcomes. It's just the same thing as I said with the last slide. So again, how does treatment with creatine change language development in a clinical trial? Then we say language development is an outcome of our clinical treatment with creatine. Next one. So again, symptoms versus outcomes. Symptoms that are characteristic of creatine transporter deficiency can be used as outcomes in trials. I think we have understood that now. But of course, we have to look really carefully what kind of symptoms are we using, because we need to use symptoms that are specific for the condition. And language delay definitely is something that we know is very characteristic, for example, of creatine transporter deficiency. But children with creatine transporter deficiency also could have fever or cough or runny nose or diarrhea, right? Things that any other child could have as well. So this would not be an outcome in a clinical trial. We would not look at these kind of common disorders that everybody can have. Now, core outcome sets, cores are outcomes that apply to all patients with creatine transporter deficiency, for example. Intellectual disability and brain creatine deficiency are core outcome sets for creatine transporter deficiency, because all patients with this diagnosis have these presentations, have these symptoms. But we also know that there are children with this condition who also have constipation, which is quite, which can be quite persistent. But it doesn't occur in all patients, but only in some patients with creatine transporter deficiency. So therefore, constipation is not a good symptom to include into a core outcome set. Next one. So again, core outcome sets, and this is actually the title of our project. So core outcome sets for creatine deficiency syndromes are a set of outcomes that apply to all patients with creatine transporter deficiency, for example, or with GAMT deficiency. And intellectual disability is a core, whereas constipation is not a core outcome. Next one. So looking at cause again, I think the last example where we showed that there are some symptoms that are shared by all patients with a condition and others that are only shared by some of them. This means that core outcome sets are the least common denominator of outcomes that are applicable to all patients. So we have to make sure that everything that we put into a core outcome set applies to everybody with the disease. Because it's important, because if we can use these core outcome sets in all clinical trials that will be done in the future, for example, for children with creatine transporter deficiency, we can compare the results of all these trials. We can do something that's called meta-analysis of a number of trials, which each of them only includes a small number of patients because it's a very rare disease. But because we can put all the results together, because they look all at the same outcomes, at the end, we come up with a higher patient number. And the higher the patient numbers, the more significant, the more convincing are the results of a clinical trial. Next one. The other thing is we need to know is that those core outcome sets that we're going to develop need to cover various domains of presentations of symptoms. And so there are some domains that are pretty in almost most of the many other rare diseases that we can distinguish. So there are the biomedical domains. So for example, brain creatine or guanidino acetate in the blood, EEG, MRI, these are all biomedical outcomes. These biomedical outcomes have some advantages, namely that they can be measured quite accurately and objectively. So it's clear if somebody has low brain creatine, there's nothing to doubt about it. However, these biomedical outcomes do not really tell us what do they mean for how the patient really develops, how the patient really feels, you know. So they don't tell us how do they apply to quality of life or adaptive functioning, how do they apply to abilities, skills, emotional well-being. But there are other outcomes that would describe these kind of outcomes like quality of life much better. Another domain is the growth and the development, which is kind of clear to understand: weight, height, cognitive, speech development, behaviors, or behavioral syndromes like autism. And there's also an outcome domain which often is forgotten in clinical trial or in our kind of considerations to design a clinical trial, and that's the healthcare utilization system, the utilization of the healthcare system. So, for example, would a treatment change the frequency of hospital admissions? Would a treatment change, for example, the time that the parent spends at home with their child and cannot work? Or would it change, let's say, the needs of a child for physiotherapy, for occupational therapy, and so on and so forth? So these healthcare utilization outcomes are becoming more and more part of all the clinical trials and should be integrated in our core outcome set as well. Next one. Another consideration is that core outcomes should be measurable, right? Brain creatine, EEG, MRI are measurable. We know that. We have devices and we have techniques how to measure that. We also can measure developmental and behavioral outcomes with scales, but they are very generic. So these scales usually don't tell us much about individual particularities of a patient. And sometimes it happens that that if you treat a patient with a new treatment, those behavioral scales would not change, but the family says, well, this child is a completely different child. They communicate much better. They are less hyperactive, but this might not be really captured in the scales. So therefore, therefore, we also have to make sure that we integrate meaningful outcomes for patients. So exactly those outcomes that I described, so outcomes that the parents themselves can observe with their child. For example, brain creatine is something that might change during a treatment, but it doesn't necessarily mean that it needs to improve behavior, but the improved behavior is the more important thing for the family. Same for guanidino acetate in the blood can be improving a lot when we treat with creatine and with ornithine and with diet. But more important for the family and for the patient is, for example, that the sleep is better or that seizures are better. So this is what's the difference between those biomedical, well measurable outcomes and the meaningful outcomes for patients. And if we speak about in the context of clinical trials, of course, these outcomes need to be able to change short term, because a clinical trial only can last for a year or maybe maximal 2 years. But there are some outcomes that don't change within this time of the trial. So we need to choose outcomes where we know if there is an effect of the treatment that they would change. We know that intellectual disability is an outcome which everybody talks about in children with creatine deficiency syndromes because they have it, but it's not an outcome that can easily change short time, or at least we cannot measure the change very well. Whereas behaviors and functions change easier if there is an effect of the treatment, and we have to find ways how to measure that. So they should be measurable, they should be able to change short term, and they should be meaningful for patients. Next one. And when we speak about meaningful outcomes for patients, so we kind of have another definition, and that's the patient meaningful outcomes, or PMOs. PMOs, patient meaningful outcomes, is everything that's important for the patient and for their family. Some PMOs apply to all patients and they can be part of course, whereas some other PMOs apply only to individual patients. And they would then be part of an individual or personalized outcome set that is just important for this particular patient. Next one. The other thing is that, and that brings me now to the importance of participation of patients in the development of these PMOs, because it doesn't necessarily mean that outcomes that are considered meaningful by clinicians are the most meaningful for the patient. So if I have a patient and the patient has a problem with communication and with mobility, right? And I think, well, it would be great if that patient could maybe improve their ability to walk, or to do any other kind of motor activities. It could be that the family says, well, for me, it would be much better if my child could communicate better, if I could have eye contact, or if I could understand what he or she wants. So this is a difference between the clinician meaningful outcome and the patient meaningful outcome. We also know from clinical trials for muscle diseases, so Duchenne's muscular dystrophy is one of the most frequent and very severe progressive muscle disorder that leads to loss of motor functions. That initially those trials measured the ability to walk, or the ability not to lose or the fact not to lose the ability to walk. But then listening to parents, they said, I don't really mind, or also to patients, if I have a little bit better ability to walk. More important for me is that I can use my hands, because I want to use my iPad. I want to use all these tools with my hands. So that was a very interesting lessons that was learned a couple of years ago with these clinical trials for Duchenne's muscular dystrophy. Another example is for children who have seizures. Normally, if somebody has seizures, sometimes you have to give a lot of medications to suppress those seizures. But most of the time, suppression of seizures also means reduction of alertness. So children would be more tired, would not be that attentive in school. So then always the question is, what do we really prefer? Do we prefer a reduction or a complete resolution of the seizures at the cost of the alertness? Or do we take into account some seizures, but the child is still alert? So that's also most of the time a question between a clinician and a parent, what is really important for them. Therefore, I think I was able to make it clear that patient engagement is really needed to define those PMOs. And our PCORI grant allows us to do that. Next one. So what have we learned? We have learned that outcomes are symptoms or manifestations of a condition. And we talk about outcomes when they are used in the context of clinical trials. Core outcome sets are a number of outcomes which apply to all patients that are supposed to be studied in a clinical trial. And patient meaningful outcomes are those that are important for patients and families. They can either be part of course because they apply to every patient and family, or they can just apply to single patients. Next one. Yeah, and then I would like to talk a little, Heidi, should I talk about the project as well, or do we want to have some discussion? Are there already lots of questions?
We could switch to some questions quickly and see where we're at if you'd like.
Okay, yeah.
Okay, first question. Seizures seem to be common, but not found in all. So you would not use them as a COS?
Yes, I think we probably would not use it. We of course, we have to, and that brings us then to the project. We have to do a careful analysis of the manifestations and of the symptoms that have been described. Because if we find, for example, if we find in the literature, when we do a literature review or a review of all the registries, like the INVITA registry or the NORD registry, and when we see that seizures were reported, let's say in 80% or in 85% of patients, right? I think we still could consider it as a core outcome. Whereas if the seizures are only described in 25%, I would not consider it. So the answer to that question is we also have to look quantitatively into how often these kind of symptoms occur in patients.
That makes sense. So perhaps it's impossible to find an outcome that is in 100% of the population. And would you say that is part of the reason that you work with a core outcome set rather than just one outcome?
Exactly. But we work with a core outcome set, which can, normally those sets contain 10 outcomes. Should not be much more, but but we would have room to put everything in that we think is shared by most of the patients, because of course there are always, in those rare diseases, there are always milder cases, always cases that are different from others, but we still would look at the majority.
Okay. I have a question about, similar question about the seizures, which I feel like we've answered. And then they say, I am also curious about hyperactivity, ADHD, in the same vein, as its impacts can be huge for the caregiver, but also this may not be 100% of patients with CTD.
Right. So the ADHD is actually something that I would, put under behaviors. And from my clinical experience, with not only with creatine deficiency syndromes, but also with other conditions that cause developmental issues in children, the ADHD, the hyperactivity, the inability to focus is something that's very, very important for families and for patients, because it determines how they are doing in school. It determines how they're behaving at home with the family, how well the family, how they determine the well-being of the family. So this is a very, very important, I would say, outcome for patients, for parents. It also can be measured somehow. And again, yes, it probably won't occur in 100%, but I think it probably occurs in the majority of cases. Again, we can see that we will see that from the literature review, and hopefully also from the analysis of the registries that you have already populated with lots of information.
Great. One more question, a couple more. For GAMT patients, would the PMO depend on the current severity of the patient? In other words, for more severe patients where treatment didn't begin early in life, seizures may be a PMO. However, for patients with early treatment, an easier supplementation may be the most important PMO, because the level of severity of the disease doesn't have as great of an impact on their daily life. They have no seizures and they live a relatively normal life. And I do think GAMT will be very tricky, because there is such a big difference between patients.
Absolutely, I totally agree. I think it's easier to talk about core outcome sets when we speak about creatine transporter deficiencies, because we don't have, a treatment yet. Also, I appreciate that also for creatine transporter deficiency, there is a spectrum of presentations and of severities. And in GAMT deficiency, I think we are just speaking about two different patient cohorts, right? The ones that have been treated very early, they have not many symptoms, if at all. And others that haven't been treated early, or that are not even treated, when they are diagnosed later. It's a completely different type of presentation. But maybe some of the outcomes still might be shared, also in different severity degree. Some children, even if they're treated very early, GAMT patients treated very early may still have some language problems, of course, much, much less than an untreated child, but language still might be an issue. So therefore, we also, of course, need to talk about the severity of the symptoms. That's all that we have to work out with the core outcome sets.
So did I understand correctly? Potentially there could be two core outcome sets for GAMT?
Yeah, it could be. I mean, of course, we try we will try to make only one, and to make it such that it applies to everybody with GAMT, unless this child is completely healthy, right? Doesn't have any problems, but then, I mean, we cannot assess anything anyways. But I mean, we will try to get only one, but I can't predict what will be the final outcome.
Okay. For an N of 1 trial, is the core outcome set the starting point, and then the outcomes are considered for the individual patient?
Yeah, I know that I had that buzzword N of 1 trial in one of the slides, but I didn't talk about it. That's maybe something we should do in one of the next webinars. N of 1 trials are actually different from the regular trials. In regular trials, we are looking at groups of patients where we just try to assess the effect on the outcomes of the whole group. So we don't look at the single patient. N of 1 is something where we look at the single patient. So we look at how was the patient at the beginning, how was the patient at the end of the treatment. This is actually also the real world experience of the families, right? So they are not so much interested, they don't feel how does the whole group of patients that are included in the trial respond. They just see how their child responds. So N of 1 is very important for the families, but it's also an important methodological tool because sometimes patients are so different from the rest of the patients that we just need to assess them as an individual. And yes, of course, we will use the core outcome sets for the N of 1 trials as well. So if we just look at one single patient, we will design that N of 1 study such that we look at the core outcomes, and but the N of 1 also allows us to look at outcomes that are more personalized, so that are only true for that particular patient.
So with core outcome sets, typically we are building these to assess the effectiveness of a treatment. And would you say that in a way you tie your hands in that process, but when you're working with a governing body like the FDA, because you need to present ahead of time, here are the core outcome sets we expect to change. And if there is a surprise outcome that is not included in those outcome sets, but is important and significant, there's this risk that you didn't accomplish what you expected to set out to accomplish. And on the flip side of that, is there more flexibility with an N of 1 trial? And is the FDA more flexible with an N of 1 trial where you have an unexpected outcome?
Mm-hmm. Yeah, I think, just speaking about FDA and regulating bodies, this is of course very important. They must accept what we measure in the clinical trials. They must say, well, this makes sense. Also in their kind of ways of thinking and evaluating. And that's why we are undertaking this effort, to develop those core outcome sets with methodology in the background. Because if we use the currently accepted and applied methodology to develop those core outcomes, that will also be accepted by FDA. So if we can show that we have developed the core outcome sets with the literature review, with kind of, consulting families and experts, which I'm going to show maybe in one of the next slides, then this should be accepted by the FDA. And we also, of course, want that these outcome sets are accepted by other researchers or by companies that develop a treatment. Because, as said earlier, we want to make sure that the results of those trials are comparable. If it then comes to outcomes that are more individualized, right, which do not belong to the core outcome set, it will be difficult to convince anybody that this is a significant change that they should accept for everybody. But if we combine it with core outcome sets, I think we also can capture those patients who are a little bit outside the kind of regular presentations.
Great, that makes sense. One last question. When considering outcomes, is the presentation of symptoms looked at as having ever occurred or currently experiencing?
Yeah, if we look at these outcomes in the context of a clinical trial, so that we want to include a patient in a clinical trial, then it needs to be something that is currently occurring. So for example, if somebody, let's take seizures, and let's say that seizure is part of a core outcome set. Also, it doesn't occur in 100%, but maybe it occurs in 85%. So we kind of put it into the core outcome set. So if the patient has seizures at the time they are enrolled in the clinical trial, that's good, because then we can measure it. If the patient had seizures in the past, but for some reason the seizures have been resolved, then of course we cannot assess the response to the treatment to seizures. However, this does not mean that such a patient cannot be included in a clinical trial, because we will not only have one outcome, we will not only look at seizures, but we have a core outcome set. So where there are all these particular domains, and that's why it's so important to look at the domains. You know, we have those biomedical domains, the creatine deficiency in the brain, we have all kinds of blood tests, we have EEGs, we have MRIs, and then we have functional tests like, you know, we have IQ tests, and then we have some patient meaningful outcomes. So most of the patients will fit in most of those core outcome sets.
Great. Okay, that's all the questions we have so far. So would you like to go into this next slide or go further down?
Yeah, let's yeah. So the aim actually now of the project is to develop those core outcome sets, and we want to include patient meaningful outcomes into the core outcome sets. So this is something that's new, and I don't even know whether we will be able at the end, because if we want to include patient meaningful outcome sets in the core outcome sets, we need to have some of the patient meaningful outcomes need to apply to the majority. So I'm pretty confident that it will happen, because what I know from patients with creatine deficiencies, there are lots of things that are important for parents, which they share all. But as I said, we also will include some of the PMOs into the course. And we will do that for GAMT and for creatine transporter deficiency. So this will be two different iterations of the project. We don't do it together, but we will do it first for creatine transporter deficiency and then for GAMT deficiency. And we will develop standards for measurement also, because we need also to know how can we measure those outcomes, and the measurements also need to be standardized. So everybody who uses those core outcome sets in the future also need to measure them with standardized measurement tools. For example, if you look at behaviors or at ADHD, there are all kinds of ways how to assess, all kinds of questionnaires that you can use to assess ADHD or to assess other behaviors. So we will have to look into the tools that are available, and then to find out the ones that are most suitable. So those that are kind of easy to apply. It shouldn't be tools that can only be applied in 5 centers, you know, on the world, and others cannot, because they just don't have the ability to do it. So it needs to be something that can be applied by a wide range of centers. And it also needs to be something that has been validated. So where we know that when they measure something that they really measure the right thing. So this is the second part of the project, actually. And in all the two parts and all the parts, we will engage the patients and the families. So in the creation of PMOs, of course, because it's really the call for the families to tell us what are the PMOs for them, but also in the creation of the whole core outcome set. And finally, also in the development of the measurement tools. So it's going to be a huge also commitment from the patients to help us with that. Next one. Yeah, and I think we talked about the utility already. So what is it good for? It's good for that we can use, these COs and PMOs in trials for new therapies, that we can motivate researchers and also industry to use those COs and also, make sure that NIH and other regulatory bodies approve what we have created and to make the results of clinical trials comparable. Next one. So approach one, so we have two approaches. The first approach is that we will collect information about symptoms with a formal literature review. I mentioned that already before. So we need to know from what has been published, how often does an outcome or a manifestation occur in patients. And so there are ways to do the literature review. It's not just that I'm reviewing the literature that I know already, but I need to make sure that I capture all the literature that's available. There are methodological tools how to do that, how to put the search term into search machines, and how to kind of select those articles that we need. So this is what we have tried, what we have started now already. And we also will look into the registries for creatine deficiency syndromes, because they also provide a lot of information, which not necessarily might be captured completely in the literature that has been published. And then we will, when we have all that information, we will create those classes, those categories. So we will assign everything that we find, is it more biomedical? Is it more growth and development? Is it more quality of life outcome? So that we already at the beginning can assign what we find in the literature to these categories. Next one. And then when we have that whole package, which is of course much too much, remember when we speak about core outcomes, it should be plus minus 10, right? So we have to ask physicians and parents to select the most important ones. And this is done by some kind of surveying techniques that are called Delphi. There are other ways to do it, but normally most of us are doing Delphi surveys where we survey patients, families, physicians, asking them, giving them some kind of questions and asking them what would be their preference. And we also will do that for some questions with focus groups, which means there will be a group of physicians or a group of parents who will be asked certain questions in a group, and where those questions will be answered in the group. This is actually provided by the ECHO model that our project has been signed up to. So, and as said, narrowing down is an important step. In iterations of Delphi focus groups might be necessary, so we might have to do more than one focus group. And finally, the selection, the final kind of would say the final selection will be done with patient and physician expert groups. Next one. And as we said, we will do in parallel PMO with PaReNts. Here we will use the ECHO model for the focus groups. Group of parents will participate in meetings together with physicians and clinical experts. And here the parents will report about their experience with their child, and we will listen to them, and we will write up everything they said, and we will further analyze those experiences and to come to those PMOs and to define those PMOs together with the families and the experts. Next one. I think I spoke already about measuring. We don't need to talk about that anymore. So one major component, which is secondary, which is the second part of the study, is that we have to come up with recommendations how to measure all the goals which we have developed. Next one. Yeah, that's all. And of course, this is a very I would say very ambitious time schedule, but I think that in 2 years' time, we should be able to have the project completed. And as you see that within year one, from 6 to 12 months, most of the all the activities will have been started. And that in year two, between 12 and 24 months, we will just, further work on those objectives and with the end results that we will have those core outcome sets. Yeah, that was it, what I wanted to say. There are still a lot of things that are open, so we will learn many things by doing together with the experts and with the parents and with the families.
Okay, thank you so much, Dr. Stockler. I learned a lot from your presentation, and we have one more question that's come in. Just a fun question. Are the parents going to help with the literature review?
Well, if there's a parent who knows how to do that, we would be very happy. But we have the literature review has been started by Sarah and by Delia. And I think parents will not help in the first step of the literature review, where we just search all the articles that have been published, where we just extract all the information that we need. But when it comes then to narrowing down and to kind of, to make the first selection, that will be the first time that the parents will be included. But if there is somebody who wants also to help with a literature review, that would be great. So what we are currently doing is, once we have all the articles, we have to read them all, and we have to, every single article, we have to extract everything that has been described in these articles that is about symptoms and manifestations. So if there's somebody who is, I would say, who is experienced in reading medical literature, it would be great, because we need at least 2 reviewers. And this will be Delia and Sarah. And then we need somebody whom they can ask if they have some questions, whether they should or should not extract something that they find in the literature. That will be myself. So there needs to be at least 3 people involved in that literature review. But if we have somebody else that could help, it would be fantastic.
Okay. One more question came in. Will the trial be primarily for CTD at this time and a second trial for GAMT, or will they be done simultaneously?
The development of the core outcomes will be done in a row. So we will start with the CTD. But when we do the GAMT, at least we will start with the CTD with a literature review, because we cannot do GAMT and CTD together. These are 2 different conditions, and it could be that the core outcomes look differently. So we cannot put them together just because they have something to do with creatine. So we decided to go for the CTD first for various reasons. But Of course, when we come to do it for the GAMT, we have already taken a huge learning curve. So the GAMT will be probably much easier and will be much faster than the CTD one.
Very good. And the difference is months, not years in the timing.
Yes,
Correct?
yes.
Yes.
Yeah.
Okay. Okay, great. And then I was just going to preemptively maybe answer some questions that the community might have. You mentioned the Invitae and the NORD registries, and I didn't want anyone to be confused on that. The Invitae registry is an old registry that maybe some of the parents that have been around longer may have answered some surveys in. The NORD registry is the one that you hear about all the time from ACD. It's the creatine info, and that's the one that we're currently working on, but there's valuable data in both. So both are being looked at. But if you would like to make sure that your meaningful outcomes are heard and collected in this early process that Dr. Stockler is working on, make sure that you have done your PMO survey in the NORD registry, because that is being looked at. And if you have any questions, you can reach out and ask me. If you would like to be a parent participant in this process, make sure to submit your application. The deadline is the end of the month. And then we will review and get back to everyone and let you know if you will be one of the 20 families that are involved. And if you missed if you missed Maureen's presentation last week, it is on this same page. And I really recommend reading it or watching it so that you get the whole big picture of this project and how it is important to families. And then last, let everyone in the community know about your experience, what you've learned today, and let them know it's not too late to apply. We would like everyone that applies to watch both recordings so that they understand what they are signing up for. So that is it. Thank you, everyone. Have a wonderful weekend. And thank you, Dr. Stockler, for the great presentation.
Thank you.
Bye.
Looking forward to work on that project.
Me too. Thank you. Bye.
Bye-bye.